joining us. And let's wait.
We can wait for a couple of minutes, then we.
जी आप अपना वो तो बंद कर लो, स्पीकर बंद कर लो जी। बताइए।
Assalamu alaikum, Professor Khubaib Shahid sahab.
जी वालेकुम अस्सलाम।
Professor Khubaib Shahid is with us. He is currently Central President of the Pakistan Islamic Medical Association, and he is Professor of Radiology at Medical School in Lahore.
शुरू कर लें
जी। Yes, up please. Sir, Professor İlhan sir, can we start?
Yes, it's for me. Okay, if you ready, should we start?
Dr. Iqbal Khan would, sir, Dr. Iqbal Khan.
बिस्मिल्लाहिर्रहमानिर्रहीम। इन्न फी खल्क़िस समावाति वल अर्दि वख्तिलाफ़िल लैलि वन नहारि लआयातिन लिउलिल अलबाब الذين يذكرون الله قياما وقعودا وعلى جنوبهم ويتفكرون في خلق السماوات والأرض ربنا ما خلقت باطلا سبحانك وقنا عذاب النار. صدق الله العظيم. It is my prime privilege to introduce my brother from Turkey. He is a professor of medicine, medical ethics and history, and currently he is leading the Faculty of Culture and Social Sciences at Turkish-German University in Istanbul. Professor Ilham has over 180 publications. He is a medical graduate and also graduated in Islamic Sciences and Oriental Philosophy. He has been studying in Turkey, in Istanbul, in Germany, in Canadian Institute of Ethics, in Duke University, and in German University. Currently, he is also heading different committees at the national and international level, mainly related to medical ethics. He has a great capabilities to interpret the ethical issues related to clinical practice, research, and also in relation with the social sciences. So we have a privilege to have this very educated and very highly respected professor from our brotherly country, Turkey. And we are very thankful to Brother Ilham, who is very kindly consented to join us today to talk about the principle of basic principle of ethical issues related to medical practice. With this, I request Dr. Ilham to kindly, I'm sorry if I skip, because you have a very long CV. I read your CV just made in abstract, and but we are unable to introduce you because of your great contribution in medical ethics. We couldn't be able to find people of this caliber in other place. Alhamdulillah, he is with us today, and he will introduce himself a little bit after our introduction. This I invite Professor Ilham to kindly come up with and please enlighten us with your achievements over the last few months. I met you lastly in a medical ethics seminar in Istanbul University, but I strongly believe that you have much rich CV other than which I told in few words. They are not enough. So with this, I invite Professor Ilham to kindly.
Yes, dear Dr. Iqbalhan, dear Dr. Tahir, dear colleagues. At first, many greetings, many salams from Istanbul. It's for me an honor to be here and to make my presentation. I participated in 2007 FIMA Congress in Istanbul, and it was very exciting and very interesting international Congress for me also. I would like to show at first my presentation. I hope I can do this. Can you see my presentation now, Dr. Iqbalhan? Okay. And maybe I can
yes,
make
we can see your presentation. Can you? Yes, that's fine.
Yes, let me give a very short information or change of my biography. So I changed my university 2 weeks ago, and I am now at the Istanbul University in my old Istanbul Medical Faculty. And maybe for you, one thing would be interesting. I was the first Muslim member of the German Ethics Council. So it is a very important ethics council in Germany, and give some recommendation to the parliament and president and so on. And it was for us also interesting discussions. Maybe you can remember in 2012 about circumcision, and therefore maybe it can be interesting, this information. So my topic is today principles of biomedical ethics. So we have on the international level a discussion about the topics on biomedical ethics, and I will give at first in my presentation a short introduction, and I give also some historical aspects about the development of these development of these biomedical ethics theories, and I explain the content of the principles of biomedical ethics. It means principalism. If maybe it is important to look at first where is our topic in the landscape of the philosophy. So we have at first ethics. Ethics means in English context, moral philosophy. So we make a decision between philosophical ethics at first and descriptive ethics. Descriptive ethics means the science discipline which make descriptions or explanations about some moral cultures in different societies, and also in history. So in philosophical ethics, we have meta-ethics. So this is the theoretical level of normative terms. And we have also normative ethics in philosophical ethics, which contains some ethical theories. For example, virtue ethics, it's based on the Aristotelian philosophy, deontology. The main philosopher of deontology is the famous German philosopher Immanuel Kant, and also utilitarianism and principalism. But I will speak today about the principalism. If we implement, practice these theoretical concepts of normative ethics, then we are in the applied ethics. And we have so many topics in applied ethics, for example, medical ethics, bioethics, or also animal ethics, environmental ethics, media ethics, and so on. This is the very short introduction into the philosophical background of the biomedical ethics. I think we have two important questions in the context of bioethics today. The first one is, why do we currently have so many ethical problems in medicine? I see there are so many colleagues with big experiments, and if you look 100 or 200 years ago, so we don't have not so many ethical problems in the medicine, because there was only one way to therapy, or two ways, but we don't have ethical conflicts and so on. The second question is, I think, why we need ethics or ethical principles in medicine. I will try to give some answers to these questions. At first, because of diagnosis and treatment opportunities have increased with rapidly developing modern medicine. As you know, as experts in the field of medicine, we have not only chemotherapy, we have surgical options, or radiotherapy, and so on. And every therapeutic concept has advantages and disadvantages. And we should evaluate the consequences of some therapeutical forms. And especially, for example, at the end of life, maybe a therapeutic concept can be interesting and successful for young people, but what about for a patient with a 19 years old patient? And therefore, we have very big increasing in the field of medicine. And at the beginning of 20th century and at the end of 19th century, the life expectations of the people in Europe was about 42, 43. So we have a double situation in Europe, for example. And you can imagine, in the last 5 or 10,000 years history of medical ethics, it is the exceptional case. So in the last 100 years, we have so successful modern medicine and very different opportunities and therapeutic possibilities. And the second reason is, with the increase of different worldviews and values, classical authorities have lost their power and different decisions have emerged. It means we can evaluate the same therapeutic concept with different consequences. And as you know, it's not only on the global level, but also in the tradition of Islam. We have so many law schools, Hanafi school and Hanbali school, and so on. And therefore, we evaluate on the moral level differently, for example, abortion. So because of the so many cultural values and value systems, we have so different ethical opinions and therefore ethical problems. And the third one is, economic conditions have become an increasingly important role in the healthcare system. As you know, there are so expensive therapeutics, and therefore we have to ask, should I give my scarce resource in healthcare system only for a specific therapeutic concept or situation, or should we allocate on the justice level the scarce health resources? And also we have so many developments in the last time, for example, in the cloning situation, genome research, CRISPR-Cas technologies, artificial intelligence, and so on. And therefore, I think it's a very, very important question for all of us, is it morally right to do everything that is technically possible to do? I think this is a central ethical issue of modern bioethics. So why we need ethics or ethical principles in medicine? Let me give a historical introduction to this question. So we had, as you know, in the middle of 20th century, Nazi human experimentation, and there was a German doctor, and he wrote a letter to Adolf Hitler in 1941 and wanted permission for human experiments with special groups, especially Jews. So they did some types of human experimentation, for example, viability at high altitudes, warming after severe hypothermia, and so on. If we analyze these experimentations, we find out that most of them was the experimentation to win knowledge in the context of war. And main focus was therefore war and soldiers. So you see here some pictures from these experimentation. Because these experimentations were unethically, and therefore at the end of these human experimentations, there was a Nuremberg trials from 1945 and 49, and 3,500 people were abused as test objects. 800 of them died, and so on. And after these trials, Nuremberg trials, 7 executions, 5 life imprisonment, and so on. What is the importance of these experiments, Nazi human experimentation, for us, for the development of modern bioethics? The Nuremberg Code, they published then during these trials, the Nuremberg Code. Important point of Nuremberg Code was in 1947, the voluntary consent of the human subject is absolutely essential. So why was this Nazi experimentation in the during Second War unethically? Because they didn't give some information about these human experiments, and they didn't take the consent of the participants. And therefore, the court said the unethically experiments like this should never be in the future. And the second important case for modern biomedical ethics or biomedical ethical principles is the so-called Tuskegee syphilis study between 1932 and 1972. So this study conducted in United States Public Health Service and Centers for Disease Control. The goal of this study was to observe the natural development of untreated syphilis. So the scientists want to look what is the normal development of a syphilis case without therapy and so on. And the region was a very poor region in the United States, state Alabama, Tuskegee, special village, I think. And participants, about 400 African American men with latent syphilis, poor people, low social class. And the scientists promised them they were receiving free healthcare from the federal government of the United States. This was the motivation for these poor people. What is the ethical problem in this syphilis study? The men who had syphilis were never informed of their diagnosis, like Nazi human experiments of their diagnosis. And the men were told they were being treated for bad blood. So this was the term for this disease among these people. And the men were initially told that the study was only going to last 6 months, but it was extended to 40 years. And the scandal of this study is none of the infected men were treated. However, penicillin was since 1947 the standard therapy treatment for syphilis. As you know, the begin is 1932. The penicillin was not standard therapy, and it first at the middle of 40s. However, they have a medicine against syphilis during 40s and 50s, of course, also. They don't give these remedies to these people because they want to continue this study. So, if we make a conclusion to this study, there was no information and no consent of the participants, and they withhold effective therapy, penicillin. So you see some pictures in this study, and there was a black nurse. I think she played a very important role to build trust bridge between the scientists and the participants, and the black people, Afro-American people, syphilis patients, didn't trust physicians, but they trusted this black nurse. So she was the bridge. And then you see here poster of this study, colored people, free blood tests, free treatment, and so on. And also the picture in village. And they made also some placebo and so on. And in 1972, they find out this scandal and finished then. And President of the United States, Bill Clinton, in this time, invited the participants of this study and apologized as a state president. So what is the meaning of these two cases, especially Tuskegee cases, for our topic today? After this scandal, the United States government said, so we should never have in the future studies like this. And therefore, we have to give a report, and we make some official regulations. And they give the scientific groups a contract, and the government says, you have to write for us a report. And the name of this report is Belmont Report. And you see here, in this report, the ethicist, lawyer, and other people said, so we need for the research involving human subjects some ethical principles. And they make two groups of ethical principles. The first one is the basic ethical principles like respect for persons, beneficence, and justice. And the second group is the applications of these ethical principles. For example, informed consent because of respect for persons, or assessment of risk on benefit selection subjects, and so on. And the one of these authors of this report was the Tom Beecham as an ethicist. And at the end of 70s, after the Belmont Report, Tom Beecham and his colleague, American colleague, James Childress from the Georgetown University, they wrote a book in 1979 with the title Principles of Biomedical Ethics. And we have in the 8th edition now, 2019. And this is the most famous book of the biomedical ethics, and which is the content of my presentation also today. And this book translated into many languages, also in Turkish, and translator of this book is my young colleague in my department, Dr. Kemal Temel. What is the content of this theory or principles of biomedical ethics? The authors of this theory, Beecham and Childress, said, so it is very complex if I found a new theory or if I make so philosophical arguments. Therefore, we have to choose most important ethical principles for the modern biomedical ethical problems. And their principles were in this book, at first, principle of respect for autonomy. It means patient autonomy. And principle of non-maleficence. It means do not harm. And principle of beneficence, do good things for your patient. And the fourth principle is principle of justice. If we look and analyze these principles, the three of them, do not harm, do good things, principle of beneficence and principle of justice, as you know, there were no new principles in the history of medical ethics of humankind. So we find, for example, principle of non-maleficence or principles of beneficence in Hippocratic Oath, but also in the monotheistic religions, also in Islam, and so on. Of course, the principle of justice. But the first principle of this theory, principle of respect for autonomy, is a little bit new, is about 50 years old. Because of this Nazi experimentation or Tuskegee study or other abuse situations in the history of ethics, they said the wish and decision of the patient is very important, and we should respect these autonomous decisions in the medical ethics. Let me give some philosophical background for this principle of patient autonomy. The principle of patient autonomy based on patient autonomy, human dignity. I think human dignity is a very central term in the modern biomedical ethics. You can justify these ethical norms, human dignity, with different philosophical theories, or you can justify also in monotheistic religions, in Islam, and so on. Let me give only two examples. From the philosophy of Immanuel Kant, the very famous German philosopher, he said, in the existence of the world and the creature, for example, animals, plants, and humankind, we find out only humankind can give for himself some moral rules, and he act according to these moral rules. And this special situation is only for humankind possible. So we cannot find in the animals these competence, we cannot find in plants and so on. Therefore, because of the competence of morality, said Immanuel Kant, a humankind has a dignity. If a creature has a dignity, he is a very, very valuable creature. And therefore, we cannot or we should not instrumentalize this creature. It means humankind. What does mean these principles, non-instrumentalizations principle of Immanuel Kant in the modern medicine? For example, if we make a medical research, of course, we want to reach medical knowledge after this research, but we cannot instrumentalize the people for our goal to have the knowledge. And therefore, we have to ask to the people, do you want to participate on these clinical trials? Also, we can justify the human dignity from the Islamic perspective. From the Islamic perspective is because in the Islamic cosmology, as you know, the humankind is the king of the creatures because he has the position of the Khalifa and God bless from his soul and so on. Therefore, the humankind is the most valuable creature of the world, and therefore he has a human dignity. From this human dignity ethical norm, we conclude that if a creature is so valuable, then he has a right to self-determination. He has a right to autonomous decision. And from this perspective, we conclude also informed consent, because the decision of the patient is very, very important. But to have this decision is a lawful decision, we have to give some information in order to make decision. And therefore, informed consent can be concluded from the ethical norm, human dignity, patient autonomy, and self-determination. But on the other side, in the Western bioethics, we have a very broad content of the patient autonomy. And this patient autonomy term contains not only right to information, but also right not to know. I think these two rights is very important, especially, for example, in oncology, and give the information about cancer diagnosis and so on, but I will give some information about these points. And based on this ethical theory, I think we have two very important principles in the patient-physician relationship. If we want to justify also on the law level, but also ethically, behavior of physician, we need at first medical indication. So every intervention of a physician without medical indication is against law and against ethics, as you know. I think I can imagine also in the Pakistani law, Turkish law, and also in German law. We need this indication. For example, without indication, if we touch the patient, for example, if a man physician touched a woman, so it is, I will say, a crime, and it can be punishable if the woman patient say, okay, I don't understand this relationship and so on. This is a very, very important, I think, point for patient-physician relationship. The second one is informed consent. So we have to, as a physician, give information to our patient, and we have also have the consent of the patient. It is not enough if we give only information about, for example, surgical interventions or other interventions. So we must have the consent. And in the European bioethics is so, the answer or decision of the patient must not be a rational decision. For example, classical example, do you know the group, this is a Christian group, Jehovah's Witnesses? Do you heard Dr. Iqbal Khan? Jehovah's Witnesses is a Christian group, and they said, so we reject blood transfusion because of our belief system. So as a surgeon, you can say, oh, the blood transfusion is a very simple intervention, and we need this because of spatial surgical intervention and so on. If a patient said, I reject this blood transfusion, you cannot do this. However, it is a medical indication for this intervention. And therefore, we need both of them. If we don't have one thing, and then the house of patient relationship go down. And I'm coming to the second and last part of my presentation. So I spoke about the very general frame of the biomedical ethics, and I explained the historical development and also the existing of this theory. And I will speak now about the content of these biomedical principles. One of them is very famous, respect for autonomy. I said before, so we need informed consent for justification of behavior of a physician. We have to look at first, according to these principles, the patient must have a capacity for autonomous choice. which criteria are required. The first criteria is the patient must be able to understand what the physician said, especially, for example, in my country, in Turkey, as you know, the physician says no enough time, and then they spoke either very quickly or they use very technical terms and so on. If someone comes to a village, they don't understand the language of the physician. And therefore, I set my medical students in every semester, in every lecture, please speak the language of your patients. I think this is very important. And the second criteria is, it is not just on understanding on the knowledge level, it's understanding of the meaning of life plans of the patient. So there is a diagnosis, cancer diagnosis or multiple sclerosis and so on. But the question is, what does mean this diagnosis for my life, for my planning? And therefore, the patient must be able to understand the content of this information. This is the second level. And the third criteria is the patient must be able to make decision. So some capacities, competencies, intellectual competencies. And the four criteria for a autonomous choice is the patient must know what is the consequences of my decision. If, for example, say the patient, okay, I accept this surgical intervention, but what does mean for the future of my life? Or I accept this chemotherapy, what does mean for the future of my life? So we need the four criteria for autonomous choice. And then we can accept the concept of patient-informed consent. So as you know, there is a informed consent formula, and we should, as a physician, give informations. But there's also, as you know, some formulas. But I can imagine also in the Pakistani law, it is not enough to give only the papers to the patient. Please read and make signature. It's not enough. So the patient's duty is to give information and to make sure that the patient has understand what the physician say. Disclosure is, I think, also important point, especially in so my main topic is intercultural medical ethics. It means one physician comes from, for example, Germany, is a German people, and the patient is a Turkish or Pakistani people, comes from the other culture. So we have, in my 22 years in Germany, education and teaching and so on, we have so many ethical problems in the medical practice in Germany. For example, my German colleagues want to say the cancer diagnosis very simple and very openly. But parents or son of the patient, of Turkish patient, they said, no, in our culture is the tradition other, and therefore please don't give this information. But according to German law, the German physician must give this information because the patient has a right to know. And therefore, I think this is also a very important topic in the principle of patient autonomy. Understanding is, I think, very important point. How can we be sure that the patient has understood our information? And therefore, my recommendation for my especially young colleagues, if you give some information about the diagnosis or disease of the patient, please ask, what do you understand about my information? I think this is a very important point, and voluntariness. And this is also very, I think, philosophical, problematical term, voluntariness. On the one side, so the patient must be free, but as a philosopher, I can say absolutely freedom. We don't have never absolute freedom in our life, because we make a decision according to our parents, neighbors, or future or society, and therefore it is not easy to have very ideal freedom situation. So this was the first important principle of biomedical ethics, and the second one is a little bit classical one. Non-maleficence, do not harm. So, as you know, we give in our lectures to our young colleagues at first no harm. But the problem is, I think, in the modern medicine is a little bit complex than earlier, because so we have to make distinction and rules governing non-treatment, or we have optional treatments and obligatory treatments. What is the boundary between optional and obligatory? So, also do not harm. What does mean do not harm? If I withhold and withdraw medical interventions at the end of life, is a do harm, or is a behavior according to the patient wishes and so on. And also we have to protect incompetent patients. Beneficence is also a classical term in the medical history of medical ethics, but in modern medicine is a little bit not so clear. Especially we have conflicts sometimes, beneficence and respect for autonomy. As a physician, you said to patients, so we have to these and the other interventions, they are good and effective for you, but the patients say no. And the most problematic area or areas in the modern medicine is if a patient cannot decide himself. It means we need then surrogate decision making for incompetent patients. Or what about with children, for example, 2 years old children or 4 years old children? So of course, the parents make decisions, but on the other side, we have sometimes the decisions of the parents is not according to interest of the child. And therefore, what should we do in these situations? And therefore, we have to balance benefits, costs, and risk, and so on. And in the especially last 20, 30 years, we have a discussion in European biomedical ethics about the quality of life. So what does mean quality of life? So can we have a list of the criteria for quality of life? Of course, we can say some very general criteria, for example, painless, to be mobile, and so on. But on the other side, what does mean painless for a healthy people, young people? What does mean painless situation for a cancer patient? And all of the criteria of quality life are subjective criteria. And therefore, it's not easy to have a criteria for every person. And my last principle is justice. Of course, justice is a very old and classical principle of the ethics, not only in ancient philosophy, but also in the Islamic philosophy, Islamic fiqh, and so on. But the implications of this principle are different. It means we have in every, also in rich countries, scarce and limited resource for healthcare system. And we have to allocate these limited resources in the context of justice. Not only the micro level, but also meso and meta level. It means on the global level. For example, we had experience during the COVID-19 pandemic. As you know, at the beginning of the vaccination, as they invented the vaccination, some European or Western countries had 4 times more than they need vaccine. In the same time, more than 100 countries on the world has no vaccination. And therefore, I think we should discuss these justice problems also on the global level. So global health policy and right to health, allocating and setting priorities and rationing and so on, they are also important points. Organ transplantation, for example, we have on the one side, we try to establish theoretical and objective criteria, but on the other side, we see in the practice, it's not easy to applicate these principles. For example, if we have only one kidney, to which criteria should we give this kidney to a patient? Should we say, okay, it's the urgency is the very important point, because if we do not translate, for example, these people will die in 2 months. But if we translate, make a transplantation, then we can maybe live 6 months or 8 months. But on the other side, if you look, the successfulness is the main criteria, then we can give the same kidney to young people, and he can live then 20 or 30 years with this kidney. And therefore, on the one side, we need this criteria, but on the other side, we see it's not easy to applicate these criteria on the practical levels. So at the end of my presentation, I would like to give a case. Maybe we can discuss, or I will try to answer your questions. So this is a very important and very famous case in the history of medical ethics, the case Karen and Quinlan. And why I choose this case, because we can find in this case every ethical principles, and we see also how difficult to apply these principles in the practice. Karen and Quinlan, a 22-year-old who ingested a harmful mix of drugs and alcohol, suffered to 15-minute periods of interrupted breathing, which left her in a chronic vegetative state without any cognitive functions. Medical intervention saved her life, but a lack of oxygen left her in a persistent vegetative state. After several months with no change in her condition, Karen's parents wanted their doctor's ventilator removed. I think this case is interesting because the parents of Karen was very religious Christian people. They said, so we are coming from God, and God will take our life, and therefore we should die in naturally context, and therefore we don't need these modern medicine investments. Mr. Croson, the patient's father, Karen's father, sought appointment as her guardian along with the authority to terminate all extraordinary medical procedures. The petition was opposed by the doctors, the hospital, the prosecutor, and the guardian at Lytham. The trial court refused the order to withdraw life supporting apparatus. The father guardian appealed. So you have to look that it was the 70s or 80s and 1976. And in this time in the United States, the right to life and duty of state to let sometime life were higher position than the patient autonomy. But on March 31, 1976, in a landmark decision, the New Jersey State Supreme Court ruled that privacy rights assured a person's prerogative to forego life-sustaining medical treatment, and that in this case, a parent could make the decision for Karen. When taken off the ventilator, Karen shocked many by continuing to breathe on her own. She lived in a coma for 9 more years, succumbing to pneumonia on June 1985. So I think it's a very, very interesting and very historical case in the history of medical ethics, because in this time was also in the United States, patient autonomy has not so higher level, but now is the situation a little bit different. For example, we have, especially in European countries, advanced care planning and some documents, and the patient can make a signature and they can describe, I don't want at the end of life, if can I not make a decision, these and other medical interventions. It's also in Turkey possible, but on the other side, we have no practice in this context. So we can ask, what is patient autonomy? What was the wishes of the Karen and Quinlan in this case, for example? And what does mean surrogate decision-making for incompetent patients? So especially in Turkey, I can imagine also in Pakistan, if at the end of life situations, for example, if the patient cannot make choices for himself, we speak with parents or neighbors or family members of the patient. But the question is this the wishes of the family members, the wishes of the patient, or wishes of the family members? So the modern biomedical ethics make a difference between these wish types. And therefore, we speak also about the best interest standard. What is the best situation? Not for family member, not for son of the patient, but what is the best interest of the patient? And we have beneficence. What does mean beneficence in the case of Karen Quinlan? And justice, as you know, we have limited resources in the in healthcare system. For example, in Turkey, 20 or 30 years ago, we had a bad healthcare system, and then 10 or 20% of the money have to pay the family members of the patient, but now it's free of charge, everything in Turkish-German, Turkish healthcare system. And my colleague said, so because it is free of charge, family member want every time maximal therapy at the end of life. So there is, I think, also a very big problem. Okay, my my conclusions. So principles of biomedical ethics, as we see, I think three of them, beneficence, non-maleficence, and justice, are not very new in the history of humankind. We have also in Islam, Christianity, Jewish religion, but also in the Hippocratic oath. But the patient autonomy is a little bit new. And maybe for us Muslim physicians, what does mean patient autonomy in the context of our medical thinking, in the context of our Islamic belief, and so on? Maybe we can discuss about this topic. So it is in Istanbul 1350, and this was my last conclusions. Thank you for your attention.
Thank you very much, brother, for enlightening us with the recent most evidence-based biomedical ethics and making it more wise. May I request the audience to please ask one or two questions? We still have 5 minutes to go. If you have questions, you are most welcome to ask. Professor Ilham is a very, very well-read and very qualified speaker on this subject. He is a scholar and teachers of teachers. I request you to put your questions if you have.
Sir, I'm Dr. Tahir, and I have a question regarding the decision making when there is a sick child, and there is a difference of opinion on treatment between the doctors and the parents. For example, if we have a child who needs lumbar puncture to ascertain the diagnosis that child have meningitis or not, parents would many a time refuse, and they won't accept the doctor's advice, although we as doctors feel that this is something essential in the patient's interest. How we can approach the situation?
Okay. Dr. Tahir, thank you for your very interesting and good question. I think we have the similar situation also in my medical faculty with lumbar function and other medical tests and so on. So I think in the European context, as I said, the patient autonomy has a very, very important place. And therefore, the right to self-determination has, in the context of Western biomedical ethics, a more value than the healing of the diseases. A person can reject also a very successful and needful medical indication. But if the parents make a decision about their child, the law and also ethicists say it is the not same situation like the person make a decision for himself. So the parents have to make a decision in the interest of the child. It means if a medical intervention has a medical indication, they should accept these intervention. Otherwise, okay, I can imagine if there is a simple, for example, a meningitis situation, maybe, and what about with lumbar puncture? We have the similar case in our medical faculty, and it was a little complex. The parents of the child said, after information of the physician, we accept this lumbar puncture for our child. But 30 minutes later comes the grandfather of the child. He said no. And then the parents reject their early consent. And my colleagues in my faculty could not do these medical tests. And then they give broad spectrum antibiotics and so on. I don't know what they meant. But if the situation is a very dangerous situation, sorry, there is, I think, a micro open. Dr. Amik, could you close your microphone? Thank you. But if the decision or rejection of the child makes a very dangerous of life of the child, we have to go to the court, I think. And it is possible, I can imagine maybe also in Pakistan, in Turkey is possible. The parents lost their parents' right if there is a life dangerous situation for the child. So the state say, so parents, to be parents meaning is not I can do and decide everything for my child. I have to decide the right and the reasonable decision for my child. If, as a parent, cannot do this, the state can take out these rights of parents, I think. It is in Germany possible, in Turkey possible, but I can imagine maybe in Pakistan is also possible. Why not? Thank you.
Saat 14.
Thank you, sir.
More questions?
Dr. Mumtaz Khan has raised hand.
Dr. Mumtaz, go ahead. Ask question.
Yes, Dr. Mumtaz, I'm hearing you.
Thank you so much, Professor, for a nice talk. I enjoyed it very much. I'm just talking about information sharing of cases with contagious diseases, like we do share cases like tuberculosis, or like recently we shared COVID data or something other with national and international authorities, because we are bound to share such information under international health regulations. And we do not take any consent from the patient usually. So what about this case?
I think So one thing is what you say is if there is a duty, official duty to share these information, I think we should do this. But on the other side, if there is a no duty official or law duty to share this information, I will say we have to make depends on the situation and acceptance of the patient. But especially special diseases like infection diseases, as you know, it is not just a patient, and it is also the social environment of the patient can be a dangerous situation. Therefore, I think we should give this information.
Thank you so much.
I think we have now thanked to Brother Ilham for his very enlightening presentation and making our more wise in medical ethics. We extend our warmest invitation for you, and inshallah I will send you an official invitation to come to Pakistan in October in our FEMA scientific convention, where there is a special section or a special session on the medical ethics and with special interest in Islamic studies. I might be a little bit overemphasizing, but I think the principle you narrated in your presentations are really very important, and we looked into in the Islamic perspective as well. For example, you said about the dignity, and I think indirectly in Quran it is said وَلَقَدْ كَرَّمْنَا بَنِي آدَمَ. So Allah subhanahu wa ta'ala himself, he glorified the human beings. And if you're talking about the autonomy, then there's several ayahs, several verses about that. But one of the ayah from Surah Al-Hujurat which say, Inna akramakum inda ayatkakum. And about the beneficence, there are several ayah in Quran which describe the benefits. And one of the ayah is from Surah An-Nahl which say, Inna Allah ma'allazina nattaku wallazina hum muhsinun. So inshallah subhanahu wa ta'ala, we will try to communicate more on these issues, and inshallah we will request you, and we will extend our warmest invitation to come to Islamabad in October. And we thank all the participants to spare this 1 hour for making us more knowledgeable by Professor Ilham. Thank you very much, brother, and may Allah bless you for your every effort.
Thank you very much, Dr. Iqbal Khan, for your comments and very nice moderation. Thank you.
Thank you very much, sir.
Thank you. Thank you, Dr. Tahir,
everybody,
for organization and everything. It was great.